Assalamu alaikum wa rahmatullahi wa barakatuh. So for today's lecture, it's going to be about principles of pediatrics fractures. Are pediatrics different from us? We're going to see in this lecture. So for the introduction, in the Middle East, imagine that more than 60% of the population is less than 20 years. So a lot of young people in here, a lot of kids, pediatrics. Fractures account for about 15% of all injuries in the pediatric age group. And as you all know, according to the American College of Surgeons, the most common cause of death in the young people, less than 40, is trauma. Okay, so for some statistics, boys are having much more incidence of trauma and fractures than girls. So it's about 2 to 1. So they have the double of the incidence. Physical injuries increase, as you can see in the graph, along with the children are getting older. The most frequent sites for fracture, the radius is the commonest because the most defensive mechanism for your body when you fall down is you put your hand like an outstretched hand. So it's going to be the radius and the ulna, the hand, then the humerus, foot, clavicle, tibia, femur, and fibula. So these are the commonest sites for fracture. So they used to say that children are small adults. Actually, nowadays, they're not. Children's or pediatric age group have really different features. So they have growth plates. So the physiology and the anatomy of pediatrics is much, much more different. So they have growth plates or the epiphyseal plates that we will talk about in a minute. The bone is different. The bone is more elastic. The cartilage you can see on X-ray, and we will talk about it now. Periosteum. The periosteum that we talked about in the last lecture, that it's covering the bone. In the pediatric age group, it's much, much more thicker. That's why they heal easily. And the periosteum keeps the fracture aligned sometimes. So it helps in reduction. The ligaments, age-related fracture patterns, and the physiology for sure is different. The growth plates in infants, the growth plate is much stronger than bone. So the growth plate in infants, it's much stronger than bone. So the thing that will be injured is the bone, not the growth plate. So the physical fracture is more common, provide perfect remodeling power. That's why in kids, when they have a fracture, they heal much, much faster than adults because they have growth plates, they have more elastic bone, they have thick periosteum, better blood supply. The injury of a growth plate causes deformity. Usually, if you have an injury for the epiphyseal plate or the growth plate, it might be complicated with the growth arrest from either side. So some deformities may happen. And sometimes a fracture may lead to overgrowth. How is this happening? You know, as we've said in the last lecture, that when you have a fracture, you will have the hematoma, inflammation, then the soft callus, hard callus, and then remodeling. So the inflammatory process will enhance the bone to remodel and grow more. That's why the fractured limb, sometimes it became more in length than the contralateral side. This is one type of fracture, as you can see in here, and you can see the deformity that happened. In the bone, it increased collagen to bone ratio. So the collagen is more elastic bone. So it's harder to fracture for sure, but it could still have fractures. In bones, it's very important to know that it is less brittle and it's more liable to plastic deformation. So we have to understand what's plastic deformation. If you bring, for example, a pen and you want to bend it, okay? I'm trying to bend it now, and when I leave it, it returns to the normal shape, okay? This is called elasticity. Elasticity, that the material returns to its normal geometrical shape. After a point of the force is going more and more, at this point, what will happen, it will be named plastic deformation. What's plastic deformation? That the material was bent and it's not able to return to its original shape. So it will stay on the shape I bent it. After that, when the force gets more and more, the pencil or the pen will fail and it will break. So this point is called failure of material. So we have the plastic deformation, we have the elasticity, and the failure of the materials or the fracture. So that's why, because the bones in pediatric age group is more elastic because of the collagen, it will be having a plastic deformation, it will be more elastic. That's why it might bend, it might fracture from one side. That's why they have special type of fractures, which is the torus or the buccal fracture and the green stick that we already mentioned in the past lectures. Okay, so they have less comminuted fractures because increase in cancellous bone, less cortical, more cancellous, more compressive force can be accommodated by the bone. That's why they will be having like this fracture, as you can see here. It's a buccal fracture because of the compression, and you can see it here in the distal radius. In the cartilage, it's increased ratio of cartilage to bone. That's why when you have a newborn infant and you shoot an X-ray for him, sometimes you can see nothing, just a little bones, because there is no calcification yet. Because as you all know, there was pre-mesenchymal cells that was differentiated into pre-cartilage, then it's cartilage. After that, deposition of calcium and phosphate and minerals inside the cartilage, and it's changed into bone. That's why when you have an X-ray, you can't see the cartilage because it's radiolucent, not like the bone, radio-opaque. So increased ratio cartilage to bone, it's better resilience. It's difficult to evaluate by X-ray as we've seen. So if you look at this X-ray for the elbow, this is the humerus, this is the ulna, this is the radius. You can see the radial head, the capitellum in here, and you can't see the radial head. It's empty. So this space actually is not empty. There is radial head in here, but you can't see it because it's not still ossified. Also, if you look at the distal humerus here of the capitellum, you can see a line here that shows there is cartilage too. It's not a fracture. It's just normal ossification center because X-ray can't show growth plates. Here, for example, you can see this is here the medial, here lateral. You can see here the lateral condyle is having a fracture. And you can see in the diagram in here that there is ligaments holding the lateral condyle. And when you have a fracture in the lateral condyle, sometimes it's displaced and rotated. One of the most important things in pediatric age group is the periosteum. The periosteum is metabolically active, and you remember there is two layers, the fibrous and osteogenic. It's very thick, more potential to heal. It's very thick, so it is helping the fracture to be aligned, less displacement. Age-related fracture patterns. In infants, diaphyseal fractures. In children, metaphyseal fractures, and in adolescents, they will have epiphyseal injury. For sure, they have better blood supply, okay? So rare incidence of delayed and non-union. So if you have a fracture in pediatric age group, it's very, very, very hard or very rare to see non-union or delayed union. Modeling and remodeling that we talked about in the first lecture, the process which determine the structural bone. Okay, this makes for considerable capacity to reshape fracture and deformity. That's why when you have a fracture in pediatric age group, for example, forearm fracture, which is angulated, for example, after following up for 8 months, 6 months, you will see that the fracture is being realigned just by its own, without the surgeon doing anything. That's remodeling capacity is much better in pediatric age groups. So in summary, we have thick joints, okay, thick cartilage. We have thicker periosteum. We have more collagen inside the bone, more cancellous bone. The growth plates we do have. The ligaments are much stronger. So what's the management effect? Thicker joints, you can see it on X-ray. Thick periosteum, they will heal rapidly. More collagen, they will fracture. It's not easily, it's harder to fracture, but the fracture will have specific types like the buccal and the green stick. For the simple fracture, it's simple fracture pattern like oblique and transverse. growth plates remodel deformity. So that's why if you have a deformity, it might remodel, as we already mentioned. And if the ligaments are so strong, the bone will fail first. So that's why you will see a fracture rather than ligamentous injury. You remember from last lecture, we talked about the anatomy of the epiphyses in the pediatrics. And when they have a fracture, they have specific type of fractures. We talked about the buckle and the green stick and the plastic deformation already. You can see here at the tension side, the material failed. On the compression, it's normal. So most of the materials in this world, they will fail on the tension side. What's the tension side and the compression? So returning to my pen, if I want to break this pen, I will put compression, okay, or I put force like this, pushing with my thumbs. So what will happen on this side? It will be compression. On the other side, it will be traction. Okay, so on the compression side, the material can have the load. It will resist. But on the tension side, so we have compression here and here tension. On the tension side, it can't accommodate. So usually it will break from the tension side, not from the compression. So if you look here on this X-ray, this is the compression side, this is the tension side, it failed from here. This is called green stick fracture. This here, you can see a buccal fracture. Okay, it's very obvious. This is a plastic deformation. Look at the roll of two, which is comparison of the two limbs together. On the right side, you can see the normal fibula. On the left side, you can see the plastic deformation. What we will do for this patient, immobilize for 2-3 weeks until the pain has gone, then follow up. And after 5-6 months, you will find this side looks like the other side. Point at which metaphyses connect to the physis is an anatomical point of weakness. So when you have the metaphysis and below it the physis, this is a weak point. This is a weak point. Ligaments and tendons are much stronger. We already talked about this. Periosteum is very active. Many childhood fractures involve the physis. So the physial fractures are really common. So it's 20% of the skeletal injuries. The problem is they can disrupt the growth. So there will be growth disturbances. And sometimes if the fracture or the injury is near the growth plate, it might stimulate bone growth. And what will happen is lengthening or deformity. So we already talked in the last lecture about this classification, which is the Salter-Harris classification. This is the normal. The pink is the epiphysis. If the fracture is through the epiphysis, this is type 1. If it's involving the metaphysis, this is type 2. If it's involving the epiphysis, which is the articular surface, type 3. Type 4 is metaphysis with epiphysis through the physis. And type 5, which is the worst, which is compression of the physial plate. So it's compression, and most likely it will be ending by disturbances of the growth. It's very important to know the physial layer anatomy or histology. So as you can see here, we start from like below osteogenic zone, then we have the zone of cartilage degeneration, zone of hypertrophy, maturation, proliferation, and zone of reserving cartilage. The weakest layer is the zone of hypertrophy. This zone, the zone of hypertrophy. So when you have type 1 Salter-Harris, through the epiphysis, it's usually through the zone of hypertrophy because the cells are getting much bigger very fast, so it's weaker. Okay, so in type 1, as we already said, it's through the epiphysis. As you can see in here, this is the distal radius, okay? This is the radius, this is the epiphysis, this is the metaphysis. This should be here, so it slipped. So the fracture is happening through the whole epiphysis, it's slipping. There is no metaphysial or epiphysial involvement, that's why it's not type 2 or 3. In type 2, we have an involvement of the metaphysis. That's why we have like a triangular shape. So this is the epiphysis and the fracture is coming like this. it's involving the metaphysis. Type 3 is going inside the joint, involving the epiphysis. So this is type 3. Sorry, this is type 3, as you can see in this picture. The line is going inside the joint. The line is going inside the joint, the epiphysis. Type 4 involving the metaphysis, epiphysis, and the physis. As you can see in this picture, this is the line. So it's involving epiphysis, metaphysis, and the physis itself, like this. Metaphysis, physis, epiphysis, okay? Type 5, which is the worst, you can see the compression on it. So it's crushed injury of the growth plate, which is the worst type. You can see it in here, and on follow-up, you will see that it's affecting the growth. A common question, what is the most common type of Salter Harris? For sure, it's type 2, which is involving the metaphysis, then 1, 3, 4, and 5. Don't forget to tell the family that your kid may have growth disturbances, okay? You have to tell them. It's not a complication of the treatment, it's from the primary injury. Usually type 1, even if the fracture is quite alarming and displaced, usually there is no growth disturbances, usually. In type 2, it's not affected. In type 3, it may result for some growth disturbances. Type 4, it's more and more, and it might give you asymmetry in the epiphyseal growth. And finally, type 5, which is the worst, and it might give you growth arrest. Usually result from fall or traction injuries, mostly in RTAs, road traffic accidents. It's very common, or sports or playgrounds activities and so on. An injury in the child followed by pain and tenderness around any joint may increase the suspicion that this patient might having a fracture, and he might get an X-ray and physical examination. The problem is physes are radiolucent. The epiphysis may be incompletely ossified. So as the start, the physis is not ossified. Then there is a small point of ossification we can see on X-ray. It's called the ossification center. Then it starts to grow. The younger the child, the smaller the parts visible, for sure. Don't forget on the X-ray, as we said, the rule of 2, which is 2 views, 2 limbs, 2 occasions, 2 opinions. It's very important to get to the rule of 2. So you have to compare the 2 limbs together to make sure that there is no fracture missed. The features of physial fractures: widening of the physial gap, incongruent tilting of the epiphyseal axis, and finally, mark displacement. So these 4 things might give you a hint that this patient is having a fracture. And you have to get a second X-ray after a week, approximately. So you will see a reaction and swelling and the periosteum. So you can see that there is inflammatory process for bone healing. This will give you an indication that, yes, this was a fracture. Because sometimes when you have a pediatric age group come to the emergency room, you do an X-ray, you see nothing. And you do roll of 2 limbs, you see nothing. But after a week, you repeat the X-ray, you see the inflammatory process that the bone is getting healed. What to do for the undisplaced fracture? Because they are painful, there is swelling, there is tenderness, the child is crying, so we have to put a back slab. So splinting 2 to 4 weeks, and that's it. You can repeat the X-ray if there was no signs of healing. The patient is still complaining of pain and so on. So type 1 and 2, closed reduction. So if you have a displaced fracture, you should do reduction. We have 2 types of reduction techniques: either open, closed without using your knife, opening an incision, surgery. This is mean open. Closed is in the emergency room, in the operation room, but without opening the skin. So it's closed, just traction, valgus, varus force, so whatever. So either closed or open. For type 1 and 2, usually we do closed reduction, and we splint for 3 to 4 weeks. Type 3 and 4, which are involving the articular surface, sometimes if reduction closed failed, you have to go for open reduction and internal fixation. Let's revise the fast thing about fractures. You all know that fractures are intra-articular, extra-articular. So what's the difference? You remember the secondary and primary bone healing from the first lecture. In the intra-articular, we need primary bone healing. We don't need callus. So that's why we have to do anatomical reduction and absolute stability or rigid fixation. So anatomical reduction and absolute stability. This is for the intra-articular. For the extra-articular, we have to have functional reduction, not anatomical, functional reduction, and the stability can be relative, not absolute or rigid. So two differences, intra, extra, intra, anatomical reduction and absolute stability, extra, functional reduction and relative stability. Okay. Sometimes we have complications like premature fusion. So the growth plate, sometimes it's closed because of the injury, and it will give you growth disturbances. In type 1 and 2, they have very good prognosis. Type 3, 4, and 5, they have worse prognosis. In deformities, sometimes you have asymmetrical growth or from a malunited displaced fracture. So sometimes what's happening, if you have a medial injury, the medial part will stop growing, but the lateral is still growing. So there will be going to varus. On the other hand, let's take the other way. If you're having an injury to the medial and it stopped growing, the lateral will keep growing. So it will push the limb valgus. So that's the way it's gonna having valgus or varus deformity. What to do for these patients? Usually observation. If it was very obvious, if they're having pain, if it's affecting the function cosmetically, we can go for surgery and we can do osteotomy and realign the bone later. I like this slide because it says it's really good to be young. Why? Because the fractures in childhood tends to heal much, much faster than adults. So the advantage is shorter immobilization time. Sometimes you immobilize only for 2 or 3 weeks, and that's it. Disadvantage, misalignment fracture becomes solid sooner. So if you have a fracture and it was not aligned well, you will get malunion because it's not aligned well. So do you remember from the fracture lecture that you have to restore the length, alignment, and rotation? So if you have a problem in the alignment and you left it in a pediatric age group, it will heal very fast. That's why length, alignment, rotation is very important. Length, alignment, and rotation. As you can see, I'm repeating a lot of very important information. Intra-articular, extra-articular, length, alignment, rotation, anatomical reduction, functional reduction, absolute stability. These terms are very important in orthopedics. Mild angulation deformities often correct themselves, as I already told you. The problem is rotational deformities. Length, alignment, rotation. Length, alignment, rotation. Length, sometimes the limb can accommodate. The child will grow. That's okay. Alignment, if you have some angulation, if you have some translation, sometimes the bone can heal. But if you have rotation at the axis of the bone can never accommodate rotation. So rotation is never acceptable. Rotation is never acceptable. Angulation, it might be accepted. Lengthening or shortening might be accepted. Rotation, not accepted. How to make sure of the rotation? As I told you last lecture, get the role of two joints. So one joint above the fracture, one joint below, to make sure that there is no rotation. Good. Fracture in children may stimulate longitudinal bone growth. That's why on the fracture limb, it may get more length than the other side. After casting, callus formation, but still may be fibrous. So avoid contact activities from 2 to 4 weeks. So if you have a fracture for a pediatric age group, green stick, 2 to 4 weeks, avoid contact activities. Let's go very fast with the most common fractures. We will talk about them in the upper limb and lower limb, but let's just go through them very fast. So we have distal radius, elbow, clavicle, and tibia. For the distal radius, it's the commonest, okay? Because you fall on outstretched hand, radial injury. You have to check sensation for median and ulnar nerve for sure. Be careful from the angulation and be careful when you put the cast of the significant swelling, you may cause the patient compartment syndrome. That's why back slap and observe the patient. Buccal fracture or torus fracture, usually non-displaced, just back slab, green stick, and the same. As you can see here, this is the fracture line. Here you can see the buccal fracture. No reduction needed. They are reduced okay. It's anatomically aligned. Just put them on back slab 4 weeks and repeat X-ray if necessary. If necessary. If non-displaced, okay, short arc cast. What if displaced? We should calculate the angle. I told you last lecture, each bone has a specific angle. As a medical student, you don't have to memorize them all. You can refer to your book, look at the angles. But for example, in the distal radius, we can't accept more than 15 degrees. So if it's more than 15 degrees angulation, we have to reduce it back to normal. If it's less, short arc cast, and that's it. Okay, type 1, non-displaced, short arm cast, as we already mentioned. Type 2, if it's displaced, you have to reduce it. Reduce it ASAP. If non-displaced, put an arm cast 3 to 6 weeks. And if the children or the child is older, he may take more time. If X-ray are normal initially, but tenderness, immobilize only for 2 weeks, only just pain, just signs of fracture, you can see it on X-ray even with the roll of 2, just put a back slab for 2 weeks, and re-examination and re-X-ray after 2 weeks. Okay, elbow. 10% of all fracture in children, diagnosing and management sometimes is complex. Supracondylar fracture. Supracondylar fracture. So in the distal humerus, we have the lateral and the medial condyles. The area above, it's called supracondylar. Sometimes it's hard to diagnose. Why? Because you can't see the bone, because it's still cartilage. So we have to know this acronym, which is Come Read My Tale of Love, which is CRMTOL. What are these? These are the timing of the ossification you can see by X-ray on the elbow. The first ossification that you can see by X-ray is capitellum, radial head, medial condyle, trochlea, olecranon, lateral condyle. The ages 1, 3, 5, 7, 9, 11. It's very easy, just add 2, 2, 2, 2. The fusion time, it's more difficult. It's 12, 15, 17, 12, 15, 12. So this is the time of ossification and the time of fusion. What's fusion? When the growth is done, all of the physes will fuse because you don't have to grow more. That's why at specific age for females and males from 14 to 20, the physes will close. This is an X-ray. You can see here the distal humerus. Okay, this is the ulna. This is the radius. This is the radial head. This is the physis in the radial neck. This is the lateral. You can see here on the above the capitellum, the line of epiphysis. The medial condyle in here, you can see the line too. On the right side here, look at the fracture. You can see here a fracture on the lateral condyle. Okay, you have always to check neurovascular. That's very, very, very important and mandatory. So flex, extend elbow, flex, extend knee, make sure about history, physical examination, oppose the thumb to the little finger, okay, which is called adduction, adduction. So you are checking neurovascular, you are checking for the nerves, the ulnar, the medial, and the radial. And you have to palpate for the pulses, okay, from the brachial to the radial and ulnar, and check the capillary refill. If it is not displaced, the fracture, you should immobilize, okay, in flexion 20-30 degrees, which is the least nerve tension. As you can see in this picture, you can see here that supracondylar fracture, usually it will affect the brachial artery. For the nerves, for the supracondylar fracture, usually the patient come on outstretched hand. The fracture will go posteriorly, which is called extension type, which is the most common, 95%. 5%, if it was direct trauma, this piece will go in flexion. So it's called flexion type. That's why supracondylar has two types, flexion and extension. Extension is way more common. It's 95%. And it's important to know the nerve that's going to be affected. An extension type for the median nerve, the anterior interosseous. And for the flexion type, you have to look for the ulnar nerve and median nerve. Okay. Fat pad. What's fat pad? Sometimes you can't see really a fracture. You can't see a fracture. It's called occult fracture. There is a fracture, but you can't see it. So there is a fat pad sign here that there is a lot of fluids inside the elbow, so you can see the fat pad. This gives you an idea that there is a fracture. Why supracondylar fracture happen in this area? Because it's the weakest part of the elbow joint. The patient will present with pain and swelling and potential vascular compromises. So that's why you have to check the pulses. Look at this X-ray. You can see here a lot of fluids around the joint, which is the fat pad sign. We have a line, it's very important. This is the humerus, this is the posterior cortex, this is the anterior cortex. We have a line going through the anterior cortex. It's called anterior humeral line. It should be dissecting this capitella. Okay, so if the capitella is going posteriorly, this is extension type. If the capitellum is going anteriorly, this is a flexion type. For the lateral condyle, this is the most common elbow fracture, most common physial elbow injury. You can see the fracture line, for sure. You can see the fracture line in here and the arrows, okay? Medial and lateral in here. Let's go very fast to the clavicle. The most common site for clavicular fracture, for sure, it is the middle third. It's about 80%, 15 in the distal, 5 in the proximal. You know, clavicle fracture, sometimes it may be dangerous because there is vital structures below it. That's why you have to do neurovascular examination and shoulder examination. Sometimes it's direct trauma, sometimes it's falling on the shoulder. The patient will present with pain, unable to move. Sometimes subcutaneous crepitus. You have to get an X-ray to make sure for the displacement. Usually it's conservative. Most of the times it's conservative. It's have a good healing potential, and in the pediatric age group, it heals very fast. But sometimes you have to do surgery depending on the displacement. And this sign, as you can see in here, it's called tenting. Tenting. So the clavicle is broken, going upward, okay, by the muscles that's holding the clavicle, which is sternoclavicular. On the sternoclavicular joint here the acromioclavicular, there is a muscle, okay, pulling the clavicle cephalic. So this muscle, because it's doing its action, the sternocleidomastoid muscle, it's pulling the clavicle and it's making here called a tenting sign. So it's impending open fracture. So this clavicle, because like this, it's trying to injure the skin. This is an indication for open reduction. In the tibia, it's the same, more elastic. You will have this type of fracture, which is usually non-displaced. And the toddler fracture, usually it's non-displaced, like this fracture. You put the child on a back slab for 4 weeks, and you see him again in the clinic and repeat the X-ray. The last thing I want to talk about is be careful of child abuse. Child abuse is very important. Non-accidental injuries, it could be multiple. If you have multiple fractures in this kid, you should increase the suspicion of child abuse. Various levels of healing. You have a fracture which is in the hematoma, the other one inflammation, the other one soft callus, the other one hard callus, the other one is remodeling. So you have many fracture level of healing, like the color of the bruises, yellow and green and so on. Unclear history and circumstantial evidence, like soft tissue injury, bruising, and burns, if you have burns over the kid, intra-abdominal injuries, intracranial injuries, and delayed seeking treatment. So if you have a fracture and they come after 2 or 3 weeks asking for medical treatment, you have increased suspicion of child abuse, posterior rib fracture, skull fractures, corner fracture. What's corner fracture? Because it needs traction and rotation. So as you can see in this X-ray, this is a corner fracture. It increases the suspicion. It's pathognomic for child abuse. Femur fracture less than 1 year, humeral fracture less than 3 years, sternal fracture, all of these are signs of child abuse. You can see here, a fracture is healing, another fracture is healing, another fracture, increasing the sign of child abuse. You can do bone scan for these patients to check for bone healing. In conclusion, nearly 20% of the child will have injury or fracture in their life. Consider always bilateral X-ray, rule of 2. Physical injuries are very common, but sometimes you can't see it on X-ray, so treat as a fracture until proven otherwise. Don't forget to tell the family that they may have growth disturbances. And finally, please don't forget child abuse.